Hello, my name is Jonathan Ng, current Roseman PharmD candidate of 2024. I'm currently looking for a residency in oncology, informatics, or diabetes management or organ transplant. And today I'll be presenting this PowerPoint on the guideline review of intracerebral hemorrhage, courtesy of my rotation right now, 3.5, in the ICU of Centennial Hills. Now, the reason why I'm presenting this today is because not only am I on rotation for the ICU, but it is a pertinent matter for patient care, as stated by my pharmacist, Anna Novakovic, PharmD, BCCP, BCSP. We're renowned here for neurological ICU and neurological care. Centennial Hills is the top in the valley. Therefore, this update that has taken place as of this year from original guidelines of 2015, it is very important for us to be able to look into these guidelines and see what kind of research, evidence, and updates have occurred in that time span, because making sure that we're up to date on all of the science in order to improve patient outcomes is very, very essential for a condition like this. Now, before I begin, I just wanted to start off with my definitions. This is classes 1 through 3, which show the amount of recommendation that we have for different treatments based upon not only mortality, but also morbidity, increasing functional outcomes for patients, as it has been declared by that of evidence, as seen right here, from A to C, showing the quality of evidence in the amount of literature that has been not only published, but the amount of positive outcomes or negative outcomes thereof to substantiate our points of why we make these recommendations to initiate treatment or to withhold treatment. Now, the layout of this presentation will be in 4 parts: pathophysiology, diagnosis, treatment, and long-term care. Pathophysiology, just wanted to clarify this before we continue. There is a clear difference between intracerebral hemorrhage compared to that intracranial hemorrhage. Intracranial hemorrhage is a broad term that is used to describe an overall bleed that happens within the cranium. For example, subarachnoid, subdural hemorrhages that occur in the meninges are not considered intracerebral hemorrhages. Intracerebral hemorrhages occur within the brain, within the ventricles, within the thalamus. These are intracerebral bleeds of where the vessel breaks and then bleeds within the brain occur, which then cause the conditions known as intracerebral hemorrhage. Now, when talking about the cause of why intracerebral hemorrhages occur, there are 2 main categories: arteriosclerosis and cerebral amyloid angiopathy. Arteriosclerosis is known for the breakdown of the cellular components of the deep penetrating coronary vessels inside of the brain. You see, what occurs is due to predispositions, for example, hypertension, diabetes, and age, this causes their age increases the weakness of the vessels. Due to the years and years that the patient has been just living life, there's not only wear and tear because of increased age, but also accumulation of different molecules. For example, lipids, proteins, different kinds of other molecules that then lead to immune response, that then create plaques on the outside, which then make these vessels that were once soft and flexible to become hard and rigid. And then with the addition of hypertension as the #1 risk for that of intracerebral hemorrhage, this is what leads to the bursting of the vessel. Ergo, as seen from the image right here, the bleed that then occurs and then expands thereof. And then the other reason for intracerebral hemorrhage is cerebral amyloid angiopathy, otherwise known as CAA, particularly from dementia, just because the amyloid beta peptide begins to accumulate on the cell walls and then or the vessel walls, and then causes weakness thereof. Not really as much of a hardening, but more of a degradation of the penetrating vessels, which then causes these bleeds that occur. Not really much of it is known right now. There still has to do more research to understand this mechanism of action, so now we can find ways for treatment. Etiology, this is showing that 100,000 strokes a year in the United States of America, and 10% of these are intracerebral hemorrhages. It's a very, very serious condition, just because in terms of 30-day mortality, it goes upwards of 40%, and there's severe disability based upon most of the survivors that actually are able to not pass because of this condition. Arteriosclerosis and CAA constitute 85% of all spontaneous intracerebral hemorrhages, which is why it was previously discussed. Now, when looking at the risk of populations, the elderly, individuals over the age of 55, African Americans, and Asian Americans are particularly the ones of note. Particularly when looking at Asian Americans and all the other minorities, Japanese Americans are the highest. Not only have we attributed this in research to that genetic predisposition, but also a history of chronic hypertension and alcoholism have been correlated with this finding as well. Populations that are of lower socioeconomic class are also affected by this more than that of their higher socioeconomic counterparts, as this truth has been seen in less developed countries compared to more developed countries when comparing the two. Many researchers believe that this has to do with availability and access to resources. Now, the intracerebral hemorrhage is diagnosed based upon an MRI or CT scan, as that has to be done within the first 24 hours of symptom onset. As seen from the CT scan right here, there's a visible portion that is seen that is different from the rest of the brain, thereby indicating hemorrhage. Then labs can be drawn in order for us to be able to better correlate and to be able to rule out other conditions. For example, a CBC and coagulopathy such as prothrombin time, PT, partial thromboplastin time, PTT, and internationalized normalized ratio, INR, are all indications of risk of bleeding. The higher these numbers are, the greater the bleeding risk is, such as if a patient had a normal INR of 1.0 as for regular individuals and this INR was 2.2, and we see this image, we can better understand the condition of the patient and the pertinence of therapy in that state. Along with being able to do glycemia tests, as hypoglycemia can be easily confused with that of stroke because of the similarities in symptoms of both disease states. Now, for treatment, there's blood pressure management, which is top most pertinent, and then looking at other related causes such as anticoagulant and antiplatelets, and then how important specialized care is for this patient population, along with thrombosis and thromboprophylaxis, prevention of clots, and treatment of clots thereof, treating glucose, being able to make sure that it's under blood serum glucose levels controlled, and then temperature management, seizure prophylaxis, hyperosmolar therapy, and, if need be, surgical intervention. Blood pressure management is very important, as this needs to be maintained in the first 2 hours of intracerebral hemorrhage onset. Maintaining medications that are fast onset, short duration is very, very important, as we want to make sure that if we do overcorrect, we can correct this overcorrection by just leaving no medication to be infused into the patient, as gradual decrease is very important to avoid anoxic brain injury. Maintaining mild to moderate ICH is that of 140 millimeters of mercury for systolic blood pressure. The range typically goes around from 130 to 150 if the patient has a systolic blood pressure higher than that of 160. Blood pressure monitoring for large or severe ICH is not well established, as seen from ICH score guideline. That was not stated in this guideline, however, stated in 2015, of which basically states that it's more symptoms than that of the actual CT reading, which dictates the difference between that of moderate and severe as main diagnoses. It is important that patients with systolic blood pressure that not be lower than 130, because this can cause a reduced perfusion to the brain, which can be even more severe than that of maintaining increased pressure in the brain thereof. Therefore is potentially harmful and should be regulated. Now, as seen from this flowchart, warfarin, dabigatran, DOAX, and heparin are all listed to have their respective anticoagulation cascades. It's important that this anticoagulation therapy be initiated immediately as soon as we discover what medication the patient is on, so that way we can be able to stem the bleed as soon as possible. With vitamin K antagonists, also known as warfarin, it's important to give prothrombin complex concentrate, also known as Kcentra, for rapid correction. With vitamin K, phenadione, so then that way, when these factors are initiated into into the vasculature, they can start working as soon as possible. There's limited supply of vitamin K in the vasculature, therefore there needs to be supplementation in order to be able to raise the coagulation and decrease the INR. So then that way, the patient has clotting as soon as possible to stem the bleed that is currently going on in the brain. Vitamin K antagonists with associated ICH with INR of 1.3 is recommended to use Kcentra as soon as possible to reduce hematomal expansion, as well as ensuring that if the patient is taking DOAC, for example, Eliquis or Xarelto, that they be initiated on not just Indexa Alpha, just because it's very expensive, $59,000, that they just be given a reversal agent, such as Kcentra, because this medication will be able to reverse the clotting factors and be able to stem bleed as soon as possible. Then for dabigatran, it is recommended to use this medication right here, avarucimab, in order to ensure that this 2A inhibitor is reduced as soon as possible. Now for heparin, it's interesting to note how protamine usage is dosed, such as how after 2 to 3 hours of the patient's dosage, for every 100 units of heparin to give 1 milligram of protamine, maximum dose of 50 milligrams protamine for heparin patients, because this ensures that the heparin is reversed and the bleeding risk is mitigated. And it's also recommended for protamine for Lovenox, otherwise known as low molecular weight heparin, just because it's better to have action than no action at all, though yes, it is partial reversal. Then for antiplatelet-related hemorrhages, it's recommended that if the patient is currently being treated with aspirin and will go into neurosurgery, that they be given platelet transfusions as soon as possible. If the patient is not going into neurosurgery, the patient not be initiated on that of platelet transfusion, just because risks outweigh the costs. Aspirin is an irreversible inhibitor, therefore by giving it platelets, it won't necessarily have substantial effect on long-term care of the patient. Desmopressin is currently still being studied, therefore not recommended strongly by guidelines. Now, optimal specialized inpatient care is optimal just because having a specialized unit, as seen here from St. Daniel Hills, has shown to increase survivability and functional outcomes significantly. Now, for reducing complications, it's recommended to have standardized protocol in order to reduce disability and mortality, just because when there are guidelines, there is structure to patient care and what to do in various situations that will arise. Formal protocol also is recommended to see when patients are able to take oral medications, because if patients fail reflux tests, it can lead to aspiration pneumonia when the patient begins to inhale food particles and it goes into the lungs. Very bad. Now, treatment of thrombosis, which are active clots, it is recommended not to use anticoagulation as stated previously, as this can cause worsening of the intracerebral hemorrhage. Therefore, it is recommended to use an inferior vena cava filter as a bridge for patients, just so that, that way this filter that is placed below the heart is able to stop the clots from spreading to go to the brain, if not to the lungs, cause PE, or to the limbs, which can cause DVT, deep venous thrombosis. Thromboprophylaxis includes the usage of intermittent pneumatic compression, also known as mechanical prophylaxis, the form of sequential compression devices like little stockings that compress the thighs, so that way it can help to bring blood flow throughout. Just because the patients are lying down a lot and sitting blood can start to create clots over time. Just because, with anticoagulation that can expand brain bleed as stated previously, therefore it's not truly recommended, especially for these situations. Reducing hematoma expansion, definitely. And then for glucose management, it's recommended to reduce hypoglycemia and hyperglycemia risk, treating hypoglycemia just so that way the patient does not face further brain damage, which can occur due to lack of glucose, 40 to 60. And then for hyperglycemia to be treated, 180 to 200 is very important, as increased sugar inside of the bloodstream can lead to increased infection, as there's already currently a breach that's happening in the brain infection on top of that can lead to substantially worse outcomes. Now for temperature management, it's recommended to treat elevated temperature and the usage of therapeutic hypothermia, which is when the patient is put under 35 degrees Celsius over the course of 24 to 72 hours in the attempt to preserve neurological function and reduce inflammation, hasn't really been founded upon research, therefore is not entirely recommended until further research is done. Now for seizure treatment, it's patients with impaired consciousness and already confirmed seizures that is recommended to use medications. The usage of medications in order to prevent the seizures from occurring is not recommended. It's only until patients have a seizure that they need to be continuously monitored on the EEG, electroencephalography graph, in order to confirm that they do not have seizure episodes of status epilepticus and others. Now for hyperosmolar therapy, this is recommended to reduce that of intracerebral pressure, or intracranial pressure for that matter. The two don't really matter too much just because the goal is to decrease pressure in that of the overall cranium. This is recommended to use hyperosmolar therapy in the form of either 3% sodium chloride solution, mannitol 23.4% sodium chloride solution, or 7% sodium chloride solution, as the mechanism of action is that this very, very osmolar solution will reach the permeable membrane of the blood-brain barrier and then have the fluids leave that of the cranium, because low concentration goes to higher concentration, thereby relieving pressure in the cranium. Bolus hyperosmolar therapy is considered for briefly reducing intracerebral pressure, but as one note to state, corticosteroids such as prednisone and dexamethasone is to not be used for intracerebral hemorrhage. There's evidence that shows it correlated to that of subarachnoid hemorrhage, which is an intracranial hemorrhage, not an intracerebral one. Surgical interventions that can be done include the usage of an external ventricular drain, which is where they insert the drain through the brain and into the ventricle to release fluid and thereby relieve pressure. Or to do a craniotomy, where a part of the skull is removed so that way the brain is able to swell but not be limited by the casing of the skull to relieve pressure. As seen from right here, external ventricular drain, and then all other categories thereof designed to help with such. Now for long-term treatments, rehabilitation and recovery, behavioral complications, and secondary prevention are as follows. Rehabilitation and recovery, having a good case manager, being able to get these patients out of the hospital as soon as possible to ensure good transition of care is very, very important, just because patients from mild to moderate severity, early discharge is very beneficial for them to increase independence. Prolonged stays in the ICU has been shown to increase overall negative outcomes and less functional abilities of these patients for independence afterwards. And then for neurobehavioral complications, patients with already existing depression need to be treated on CBT, cognitive behavioral therapy, or pharmacotherapy in the form of SSRIs, SNRIs, or benzodiazepines, just because it's shown to greatly worsen if not properly treated within that given time window when they're first diagnosed. And then utilizing screening tools for patients that do not have any of these symptoms for depression and anxiety, just in that way it can be caught before it is to progress any further. Now for secondary prevention, risk factors foretell recurrent intracerebral hemorrhage. For example, alcoholism, inactive lifestyle, poor diet, all of these factors definitely do contribute. Therefore, patients should be educated on lifestyle decisions to better increase their outcomes and to not have recurrent intracerebral hemorrhages. Blood pressure control is recommended to prevent recurrence, as the main concern is chronic hypertension, which does lead to this condition. Controlling it as per AHA guidelines, 130 systolic and 80 diastolic. These are my references, and if you have any questions, please feel free to contact me through that of the medium of which this video has been sent. Hopefully everybody has a great day here. Thank you for your time of watching this, and have a wonderful day.